Yes, adverse effects of blood transfusion is our today's topic. So, blood transfusion is not actually and is likely never will be without risk. It always carry significant cost because also blood is a drug, is like a therapeutic drug. So, adverse events are actually inevitable consequence of blood transfusion in spite of the myriad processes to ensure the safe transfusions. So, despite what we do to ensure that our, our blood unit is safe for the patient, always transfusion will never be without risk. So that's why adverse events always occur during transfusion or after transfusion, and then we are going to discuss them, and those are adverse effects of blood transfusion. So, adverse events is just an intended and deleterious occurrence associated with the blood component transfusion, and may occur just before or during or even after transfusion. So, adverse events will include incidents and also adverse reactions. So, these are the two different terms. The incident is just in any error that could affect quality of or effectiveness of blood products, or could have led to an adverse reaction to transfusion recipient. So this is just error. Incident is just a kind of error which leads to ineffectiveness of transfusion. So that is incident. But adverse reaction is just a harmful effect observed in transfusion recipients that is temporarily associated with the blood component transfusion, but there's no error now. There's no error. It is just a harmful effect of blood components, but it is not about an error. So then this chapter or this presentation is going to focus on non-infectious adverse reaction of transfusion as well as transfusion associated bacterial infections. So we have two types of adverse reaction in transfusion. We have non-infectious adverse reactions as well as transfusion associated bacterial infection from contaminated blood components, of course. The first part of this presentation, we are going to discuss about non-infectious transfusion reactions. So one of them is called alloimmunization to RBC antigens. So alloimmunization is just the development of non-ABO antibodies following RBC transfusion, following pregnancy or following transplantation, which can complicate patient care and can increase the risk of acute and delayed hemolytic transfusion reactions. So it is not about ABO antibodies. You know, ABO antibodies are naturally occurring antibodies. For example, anti-A, anti-B, they are actually natural carrying antibodies. But of course, for example, immunization and developments of antibody against other antigen of RBC, including Rhesus, Daffy, Kiddy, Kelly, those are significant antibodies. So they can actually they are formed normally after transfusion, which can lead to complicated patient care as well as risk of delayed and acute hemolytic transfusion reaction, depending on antibody that was developed through transfusion. So except D antigen, the immunological response to RBC antigen is very robust. Of course, about 80% of healthy D negative person who will be exposed to D antigen, they will develop anti-D. But of course, 15% of them, even with the multiple transfusion, they will not develop anti-D, isn't it? So, however, of course, exposure to other antigen can cause much lower sensitization. For example, exposure to K antigen, of course, patient develop, K or Kelly antigen, the patient develop anti-Kelly, and about 10% of them, and even anti-E, anti-small c, as well as anti-small e, anti-capital C and E as well. So with various other minor groups, of course, they will appear to be less than 3%, of course, of antigen negative individuals to develop antibodies because of blood exposure. that was the first adverse reaction. It is just about allo immunization. Of course, when you are transfusing antigen positive RBC into antigen negative patients, they will of course develop antibodies against those transfused antigens. So that's what you call allo immunization to the foreign antigens. Of course, those are RBC antigens. The second is acute hemolytic transfusion reaction. So this is one of the most common adverse reaction of transfusion. So acute hemolytic transfusion reaction is the accelerated destruction of transfused RBC due to antibody-mediated incompatibility. So this is about antibody-mediated incompatibility, which leads to accelerated destruction of RBCs, right? So, excuse me. So antibodies in the recipient's plasma will bind to the corresponding antigen on RBC and then mediate hemolysis and removal from the circulation of those RBC. So those are the antibody in recipient plasma. So acute hemolytic reaction just happen because of the preformed antibodies. For example, ABO antibodies are normally preformed antibodies or naturally occurring antibodies that are going to react to the transfused antigens. Of course, that will lead to acute hemolysis of RBC or acute destruction of RBC. But of course, even with apart from ABO antibodies, even rhesus antibodies, Kelly antibodies, as well as KIDI antibodies, but not really DAFI, because DAFI can cause delayed one. So those ones are also after the second exposure. Of course, the second exposure, the previous exposure was just formation of antibodies, and second exposure, it includes antibody reaction and destruction of transfused RBC. So that's what happened. So we can classify hemolytic transfusion reaction as acute or delayed, where the acute hemolytic transfusion reaction is the combination of signs and symptoms associated with hemolysis, just biochemical evidence as well as the serological incompatibility evidence, which means DAT will be negative. Serological incompatibility means, for example, direct antiglobulin test is positive. That is one of the signs of serological incompatibility of blood in transfusion. That should occur within 24 hours, and if it occurs within 24 hours or just during transfusion, this is called acute hemolytic reaction. So most acute hemolytic transfusion reaction will occur just within very few minutes after the start of transfusion, or just within a few hours after the transfusion is completed. Just within a few minutes, patients start to experience symptoms of acute hemolysis. So the vast majority of acute hemolysis is due to RBC transfusion, but they can also occur with incompatible plasma containing products. For example, precipitates, platelets, right? All those contains plasma, and sometimes it can also cause acute hemolytic reaction, but that is minor reactions or minor occurrences or frequency. There is a wide range of clinical severity, of course, and observed signs and symptoms in acute hemolytic transfusion reaction. So that's what you have to keep in mind. First of all, you have to know that there should be fever. Fever is the most common symptom in acute hemolytic transfusion reaction, and most commonly it occurs with chills and rigors, and pain is also another frequent symptom. Pain. Actually, pain is localized to the flanks, lower back, abdomen, as well as infusion site. So infusion site pain is very, very common. Infusion site pain is very common in acute hemolytic transfusion reaction. So also hypotension is another significant symptom, and sometimes patient will also experience shock as well as generalized bleeding. So acute kidney injury is also the following another symptom, which is detected by elevated blood urea nitrogen, which is BUN, as well as creatinine, and along with the anuria, and also shock and disseminated intravascular coagulation. If this happens, it is devastating complication when DIC and shock happen following acute hemolytic transfusion reaction. So sometimes I used to read ACP questions, the way they will just ask you, because most transfusion reactions, they manifest in the same symptoms and signs. So what we just need to understand and to keep in mind is that we have to distinguish between the symptoms and most common symptom in one reaction and vs or versus another one. For example, you can be able to find fever in contaminated blood product, for example, or just acute febrile reaction. There's also fever as well as pain. But remember, for example, pain at the infusion site, it is very specific for acute hemolytic reaction. Secondly, shock and generalized bleeding, that is also another symptom of a specific symptom of acute hemolytic reaction. So of course, hypotension is common in other symptoms. It's not really specific for this one. So that is what I want you actually to look at and try to keep in mind, right? So apart from that, likewise, hemolytic transfusion reaction can occur in patients receiving ABO mismatching platelets, where major ABO incompatibility may result in decreased platelet increments. Minor ABO incompatibility just may cause hemolytic reaction due to the transfusion of anti-A or rarely anti-B in donor plasma, especially in group A receiving group O platelets. For example, if you transfuse platelets from group O, and as you remember, platelets contain some plasma in it, isn't it? When you're preparing, for example, we are preparing random donor platelets, you have to pull plasma, at least 25 milliliter of plasma in that content, in that package, in that bag, right? So that plasma can cause actually minor incompatibility, because we are transfusing antibodies to the patient with antigens. For example, we are transfusing group O platelets, and you remember group O plasma contains anti-A and anti-B. So if you are transfusing O platelets, right, you are also transfusing plasma containing anti-A and anti-B to the patient, and that's going to lead to a particular reaction. But that reaction is called minor reaction. It's not actually major reaction. So hemolysis to minor ABO incompatible platelets actually should be considered if any unexplained drop in hemoglobin following platelet is seen. For example, that is what we call minor incompatibility of platelet transfusion. For example, when you transfuse platelets and after some time, like 3 days, you see an unexplained drop in hemoglobin or unexplained reduction in hemoglobin following platelet transfusion, that tells you that the patient to whom you transfused has got antigen for antibodies from platelets that you transfused, right? So platelets contain antibodies which actually try to destroy RBC of the patient. That is minor reaction. So the third one is called delayed hemolytic and delayed serologic transfusion reaction. Now I want to explain the difference between delayed hemolytic and delayed serologic transfusion reactions. So the definition of delayed hemolytic transfusion reaction includes a positive direct antiglobulin testing 24 hours to 28 days after transfusion with either positive elevate or newly identified alloantibody in plasma and evidence of hemolysis. That definition is quite easy, isn't it? Quite simple. But I want to explain to you the meaning of positive elevates, right? I hope you understand positive DAT or direct antiglobulin testing, because we have to collect patient blood in order to identify already or in vivo sensitized RBC. That's what we do with DAT. But what is positive elevate? Positive elevate means we do what we call elution technique. It is like to detach antibodies from RBC using, of course, different methods. It can be pH, it can be freezing, it can be chemical elution technique, or increasing in temperature, right? So that can normally detach or break down van der forces that helps antibodies to attach on RBC. So then when you remove them, they will be visible, they will be found in plasma or in what we call eluate. So that is not plasma, but like fluids, fluid, of course, in which we find those antibodies detached from RBC by breaking down the van der Waals forces that of course help that bond between RBC and antibody. So that solution that we are extracting from there is what we call eluate. So when it is positive, it means we are going to use eluate in order to identify antibodies using antibody identification screening cells, and then we do antibody, of course, that is detection of antibodies, and then we can be able to identify antibodies. And when we find that that sample is positive for antibody identification panel, then we can say that is a positive eluate. So that's a long process, but we are going to see it maybe next week. We'll see antibody screening panels and how to use the eluate in the panel, right? Then you have also to confirm newly identified alloantibody, which means just a particular alloantibody that was identified in patient plasma. Can also note that down, and evidence of hemolysis. And what is evidence of hemolysis? So evidence of hemolysis is the inadequate rise of hemoglobin. Maybe after transfusing, you remember we said 1 unit of RBC can increase 1 gram of hemoglobin in adults, isn't it? So when you expect 1 gram increase but you can't get it, that is what you call inadequate rise in hemoglobin. The second evidence of hemolysis is a rapid drop in hemoglobin to the pre-transfusion level. So which means now your patient has 6 gram per deciliter of hemoglobin, and you want to target at least 9, and you have transfused 3 units of RBC. But after transfusing, after 3 days, you find that RBC hemoglobin has dropped down to the level of pre-transfusion, which means to 6. Instead of being 9, now it is also 6. It is still 6. So that is also another evidence of hemolysis. And the appearance of spherocytes on RBC on the peripheral blood smear, as well as, of course, spherocytes are those fragments of RBC, isn't it? And then biochemical evidence of hemolysis. So biochemical evidence of hemolysis, of course, include lactic acid hydrogenase enzyme. You find the creatine kinase can also increase a bit. You can find bilirubin, as well as like haptoglobin, which is reduced because it is now there to bind free hemoglobin in the blood. So those are the biochemical evidence of hemolysis. So when you find all of them together, then we can call it delayed hemolytic transfusion reaction, isn't it? That's how I could explain it. So let's try to differentiate it from the delayed serologic transfusion reaction. This is the same as delayed hemolytic, but without evidence of hemolysis. So which means it is now the same as a delayed hemolytic, but without evidence of hemolysis. It means other things about serology. DAT is positive, right? And antibody is detected. Eluate is positive, but there is no evidence of hemolysis. So that's what we call delayed serologic transfusion reaction. Now, the fourth one is called transfusion-related acute lung injury. Transfusion-related acute lung injury. So this is what we call TRALI, and TRALI is associated with the acute respiratory distress, right? Which is leading to cause of mortality, the leading cause of mortality due to the adverse reaction to transfusion. So it will occur, of course, in almost 15% of patients receiving blood transfusion. So this is what you call a transfusion-related acute lung injury. So there is no diagnostic test for TRALI. There's no lab test for TRALI, but the diagnosis is made according to the clinical criteria and the exclusion of the possible other causes of acute lung injury. For example, patient is even experiencing lung injury, so we have to exclude other types of causes or other causes of lung injury. For example, for us to make or to establish diagnosis, we must first of all exclude the following criteria. The first criteria to exclude include absence of acute lung injury before transfusion. So make sure that patient did not have acute lung injury before transfusion. Secondly, acute lung injury during or within 6 hours after transfusion. So that should actually be inclusion criteria, right? When a patient experiences acute lung injury during transfusion or just within 6 hours, evidence of hypoxemia by blood gas or oxygen saturation testing, patient is having hypoxemia, and also radiographic evidence of bilateral pulmonary edema. So what is bilateral? So it means two lungs, like both lungs, they are experiencing edema. So bilateral lung edema. So then exclusion of circulatory overload, because this is also another reaction, what you call circulatory overload, which is called TACO. TACO we shall see down here, and the other cause of pulmonary edema. You have to exclude them. So another thing that you have to make sure of is clinical presentation of this patient experiencing acute lung injury. Those presentations include acute respiratory distress, which include dyspnea, tachypnea, and hypoxemia, right? Those are the manifestations of acute respiratory distress. And in addition, signs and symptoms of fever, rigors, tachycardia, hypothermia, and hypotension. So you can see fever is also here, as well as hypotension. That's why I was saying hypotension is not specific for acute hemolytic reaction. So, and also radiographic abnormality of the lungs, which include white out or ground glass appearance. You know that one, that is evidence of lung injury. So laboratory tests are not very helpful in diagnosis. So you have to look at these all clinical manifestations in order to diagnose acute lung injury. So, but otherwise, if you want to use lab tests, you can actually test for anti-human neutrophil antigen and anti-human leukocyte antigen antibodies, which can be done on a donor of implicated products once suspected TRALI reaction is identified. So you have to perform anti-human neutrophil antigen antibodies, right? Those antibodies can cause accumulation of fluids in the lungs. So that's why we have to make sure that we test for the presence of these antibodies. And implications has been transfused donors anti-WBC antibodies to patients at risk for TRALI. So anti-WBC antibodies actually they can also lead to TRALI, especially women donors who have been previously pregnant. These women donors who have been previously pregnant, they of course they have been immunized by the fetuses through the human leukocyte antigen, and they likely developed human leukocyte antigen antibodies. And those antibodies, they are present in plasma. And when you transfuse their plasma to the recipient is going to experience this problem. So now that is why in the UK, United States, as well as in Canada, they adopted a strategy to minimize transfusion of high volume plasma components from female donors to prevent this problem. So that's why, of course, transfusing plasma from a women donor is not really a good thing, because sometimes they have been immunized and they have anti-WBC antibodies, which can lead to the accumulation of fluids in the lungs. So now then another adverse reaction of transfusion that we can mention, it is TACO, transfusion associated circulatory overloads. TACO. The TACO is also another adverse reaction which is characterized by acute respiratory distress. So that is about respiratory distress problem from pulmonary edema, right? Pulmonary edema. So caused by increased intravascular volume because of excessive transfused fluid or too rapid of infusion rate. For example, when you just, like if someone doesn't have time to wait, they're going to increase volume. Is that a volume or just, yes, volume of blood, right? When they're increasing volume, of course, they're going to increase to do rapid transfusion or rapid infusion rate, which is going to lead to overload, circulatory overload. So that is, and sometimes it cannot even be overload like that, but sometimes patients are not able to accommodate high volume of transfused products. For example, you're just transfusing at normal rate, isn't it? But of course, because patient is having impairment of cardiac and the renal function, so the patient is not able to accommodate the fluid or the volume. So that can be a problem of overload. This can cause death. So symptoms that normally happen within 2 hours after the start of the transfusion, but may take up to 6 hours later. So TACO is generally treated by stopping the transfusion. So you don't need to do anything else. Just stop transfusion and take immediate measures to stabilize the patient. And those measures include placing the patient in upright position, right? Upright position, as well as administering supplemental oxygen, stopping infusion of other intravenous fluid, and administration of diuretic medications. This is very clear, right? This is what you have to do to stop when your patient experiences TACO as a reaction. Now, we have another reaction which is called transfusion-associated dyspnea. Yes, a question, kindly. TACO and Trally. Yeah, TACO and Trally. Yes, that's a good question. She want to know how do we differentiate between TACO and Trally. We normally look at symptoms, right? Because Trally include other symptoms that are not seen here. In fact, because you can see patients would experience, for example, hypertension, would experience hypothermia, isn't it? So that happens in Trally, but in TACO is only about respiratory distress problems. But if you look at Trally, it is, you have seen many other symptoms. Apart from that, you have seen fever, rigors, tachycardia of the heart, hypothermia, and hypotension. But of course, even tachycardia may happen. But may happen also in TACO because of the cardiac problem, because of that kind of dealing with so much volume. But Trally is not about volume. Trally is about injury of the lung. So those symptoms also include respiratory distress, but there are many differences here. There are many differences. Even if you don't use lab tests, there are many other differences. Like for example, even you could see in TACO there could be pulmonary edema, which may not be seen in Trally. It is not a primary manifestation in Trally. So Trally may just be caused by antibodies that would lead to excessive accumulation of cytokines because of the reaction of immune system, of course, WBC. But it's not immediate edema as what you see in TACO, because TACO is just associated with the overloads. That is edema of the lungs, just edema. But there could be pneumonia, which is different from edema, because edema is different from pneumonia. So those are some of the manifestations that can help you differentiate. But of course, you have to identify the cause and also patient history. If patient is experiencing problems of liver and cardiac and kidneys, that could lead to TACO, even with moderate or normal rate of infusion. So those are some of the manifestations. And of course, you have to go through the inclusion criteria for trial in order to diagnose that one. You have to go through inclusion criteria. That is also helpful to you. So that is also transfusion associated dyspnea. That is when patient only experience dyspnea. That is a problem with the respiratory distress. That is dyspnea. It is respiration distress, and it is the only predominant symptom to the patient. So this happens without other symptoms, for example, without TACO problems, without trolley symptoms like hypothermia, hypotension, and so on, and fever and rigors. They are not seen here. Patients are only experiencing this one, dyspnea. So then you just call it transfusion associated dyspnea. It's called TAD. So TAD is diagnosed by 24 hours when all other diagnoses are excluded. For example, we have to exclude TACO because also we can see dyspnea in TACO as well as in TRALI. So we have to exclude it we have to exclude other diagnoses, and then we remain with only dyspnea in the patient, and we confirm that diagnosis. So now we have also hypotensive transfusion reaction. This entity is diagnosed when hypertension is seen alone during or within 1 hour of transfusion. So we only see patient experiencing hypertension without anything else, without fever, without respiratory problems, only hypertension in the adult patients. So that is, hypertension means here we are going to use these criteria to make diagnosis. That is systolic blood pressure of greater than 330 millimeter of mercury. The decrease, a drop, that is a drop in systolic blood pressure, systole, at least by 30 millimeter of mercury and above, and also systolic blood pressure in general of less than 80 millimeter of mercury during transfusion. If this one happens, it is called hypotensive transfusion reaction. So in children, it is about 25% drop in the baseline systolic blood pressure. If it is in children, if 25% drop it happens, we can then diagnose it as hypotensive transfusion reaction. So it has been associated with the bedside reduction filters, or sometimes angiotensin converting enzyme inhibitors in acute hypotensive reaction. So it is because of bradykinin, but of course pathophysiology of this problem is not understood well. And so we have also another reaction which is called a febrile non-hemolytic transfusion reaction. Febrile non-hemolytic transfusion reaction. There is another reaction, of course, which is called febrile. Febrile is different from other reactions that can also cause fever, or we can find fever as well. So here, febrile it is one of the most common adverse reaction, where you just transfuse patients and experience significant fever, which is fever greater than 100.4 Fahrenheit degrees, and which is greater than 38 degrees Celsius, or a change at least 1 degree Celsius. That is how you can define febrile non-hemolytic. Febrile non-hemolytic. So patients are transfused and experience fever during or within 4 hours after transfusion. So with rigor and chills, without sometimes even chills and rigors without fever, it can still make diagnosis for this febrile non-hemolytic. So, but of course, what you try to check it is the increase of at least 1 degree Celsius from the baseline, isn't it? So that is febrile hemolytic, febrile non-hemolytic. So the febrile non-hemolytic is diagnosed after the patient underlying conditions and medical conditions have been excluded as a cause, right? Because sometimes patient can be experiencing, for example, bacteremia or sepsis, and when you're transfusing, you find that patient is also having fever. That does not mean that is febrile and hemolytic. So you have to exclude other possible causes of fever in the patients. So also have to look at other possible symptoms, including headache, cold feeling, mild dyspnea, and also nausea and vomiting. So when the temperature is changing at greater than 2 degrees, it is no longer febrile. So that's why you have to remember it. You have to note that one. If it is change in temperature which is greater than 2 degrees, it is no longer febrile. It is now reclassified as transmitted bacterial infection, not febrile. So then you have to look at that unit, visual inspection of the products for discoloration and clots, and then perform culture in order to test if there is actually any implicated bacterial infection. So that is the difference between febrile and transfusion transmitted bacterial infection. They are different because of the range of fever. Fever in bacterial infection is very high. It is 2-3 degrees addition to the baseline degrees. So now the ninth one is called allergic transfusion reaction. This is the ninth reaction. Allergic is also one of the most common reaction that is seen with the platelets and plasma transfusions, which occur at least 2% of transfused platelets. You find allergic reaction. So these things are happening because we are transfusing every day in our hospitals. So these things are happening. But of course, what you have to do, make sure you follow up with the nurse, because sometimes nurses are the ones who transfuse. So sometimes they may not actually understand clearly what is going on. For you also have to follow up and get in touch with them in case there is anything change. And for you are required to understand which type of transfusion reaction could be that, depending on patient symptoms, right? In order to take action, because every reaction there is some means or reaction that you could take in order to deal with that issue. So this happens actually when you are transfusing some products. So that is allergic reaction. So the allergic reaction can be classified into different types. We have what you call mucocutaneous gastrointestinal reaction, as well as respiratory and cardiovascular reaction. So when it is allergic, anaphylactic, and anaphylactoids can be used to categorize those acute allergic transfusion reaction. We can classify them as allergic reactions, anaphylactoids, as well as anaphylactic. So what happens when it is allergic reaction? So allergic reaction, patient experience moderate to mild to moderate symptoms. For example, you only find that patient is experiencing skin reactions. Urticaria. Urticaria, dermatitis. That one is one of the symptoms on the skin. And GI tract, gastrointestinal disturbance. That's also another allergic reaction. It's just moderate or mild. So the second type of reaction that happens here, it is anaphylactoid reaction, which is normally moderately severe reaction. They are not so severe, but they are moderately severe reactions where you find oral symptoms, throat symptoms, even severe gastrointestinal tract symptoms like gastric or abdominal disturbances, as well as respiratory complaints. They are also in anaphylactoid reaction. And the last stage, which is very serious, it is called anaphylactic reaction, which is very severe and life-threatening reaction, in which there is a profound hypotension and shock. There is a profound, or there is a severe hypotension and shock. So the most common manifestation of allergic reactions are mucocutaneous reaction, including urticaria, pruritus, and rash. That is primary. That is an allergic reaction. It is not yet anaphylactic or anaphylactoids. It is still allergic when you experience skin symptoms. So it is the most common. So a definitive diagnosis of allergic reaction, what is it? It is the appearance of signs and symptoms during transfusion or within 2 hours after the end of transfusion, and exclusion of other possible drug, environment, and dietary causes. That is very helpful because sometimes some drugs can also cause allergy. For example, even food can cause serious allergy, even drugs, and even weather, environment and weather. So they can cause these allergic reactions. So you must exclude those other possible causes in order to establish diagnosis. But of course, it happens during transfusion or within 2 hours after transfusion. The different diagnoses, of course, we include trial and tackle when respiratory symptoms are prominent. So you have also to check if respiratory symptoms are prominent, then you have to exclude trial and tackle. And acute hemolytic should also be excluded, as well as the transmission of bacterial infection should also be excluded in case of hypertension and shock. Because you remember, acute hemolytic reaction, it goes with shock and hypertension, the same as transfusion transmitted bacterial infections. So now the last one is, this is one to the last. It is called adverse reaction to infusion of plasma derivative products or plasma derived products. So sometimes patients who are receiving some of the plasma derivatives, for example, albumin, intravenous immunoglobulin, human derived factor concentrate, for example, factor 8 concentrate, right? They can also experience some issues of adverse events, or sometimes viral transmission. But in most cases, of course, adverse events. For example, albumin, patient can experience severe hypertensive reaction. Immunoglobulin, patient can also experience problems like headache, fever, chill, nausea, vomiting, and abdominal pain, as well as diarrhea. If someone is receiving immunoglobulin, intravenous immunoglobulin, that's also plasma derivative. So also some of them like flushing, urticaria, and so on. So albumin and immunoglobulin can also carry some adverse reaction symptoms. So then the next one is called transfusion associated graft versus host disease. So this one is very common for us, right? You know this one already, isn't it? This one, you know it, and I'm so happy that you know it, because even me, when I wrote my exam, when I took my exam, it was very hard for me to memorize it. I nearly wrote a song in order to memorize this one, memorize how it occurs, because for me it was a strange term. It was a very strange sentence, TAGVHD, right? So then you know this one, it is just a devastating event that can cause high level of mortality. And of course, this is because of T lymphocytes, just T lymphocytes overcoming recipient's immune system, and of course proliferate to destroy the recipient's tissues. That is sometimes because of blood relative donors who are giving you blood, and those relatives, they will possess antigen similar to yours. Sometimes T lymphocytes are not eliminated by your antibodies or your immune system. Then laterally they will overcome a patient's immune system and start to destroy patient tissues. That is what we call transfusion associated graft versus host disease. So I'm just explaining that one like that, because you know that we've been talking about this one several times, and we are still talking about it later as well. So that is a common thing in blood transfusion sciences. And then finally, we have what you call post-transfusion papilla. Post-transfusion papilla. So this one is called PTP. This is also another problem which is characterized by sudden and severe drop in platelet count after transfusion. So because of alloimmunization to platelet-specific antibodies from prior transfusion or pregnancy. For example, we can say that recipients who has been receiving blood transfusion unit, for example, platelets or even RBC or even plasma, maybe the patient was immunized and developed some antibodies, especially when you are transfusing platelets. So when patients develop antibodies, those are called allo antibodies against platelets. So those antibodies, when you transfuse platelet later, those antibodies will destroy platelets, and you find there is just a sudden drop in platelet counts, as well as, of course, a sudden drop after transfusion, after 5 days of transfusion. So you find that platelet is very reduced because of preformed antibodies, of course, during exposure. So diagnostic definition is thrombocytopenia, which is less than 20% of pre-transfusion accounts, and demonstration of antibodies against platelet-specific antigen. So those antibodies will include antibody against human platelet antigen A1 and human platelet antigen 3A. So those are the antigen that will be targeted by those allo antibodies. So that's also one of the questions that you sometimes see. So thrombocytopenia is very severe, and over 80% of patients will experience less than 10,000 platelets, so per microliter of blood. So that is thrombocytopenia. So then you find also adverse metabolic effects of transfusion. For example, this is just a simple that when a patient is receiving blood units, for example, citrate toxicity and hyperkalemia, that is one of them. When someone is receiving citrated blood units, so that citrate is toxic. It can cause hypocalcemia and hypomagnesemia, and also metabolic alkalosis. So this happens because of citrate metabolism, because citrate is anticoagulant, and of course, meaning that transfusion you cannot remove it. You will still transfuse it with the blood, so it can cause problem, as well as, of course, hyperkalemia, especially during storage of blood. Intracellular potassium can leak out from RBC, and then it becomes so much. So it can be a great concern for neonatal transfusion and sometimes premature patients or premature infants. So it can be a serious problem. So for us, in order to correct that problem, to prevent hyperkalemia, we must transfuse at least fresh RBC to the neonates at least 7 days old, less than 7 days old, in the fridge, in order to avoid that hyperkalemia in small babies. So otherwise, if not, we have to wash RBC in order to remove excess potassium and then transfuse it. Otherwise, we can also do irradiation, because premature infants of less than 1.2 kilogram, we must always irradiate blood units. Finally, we have transfusion transmitted bacterial infection. So this is another type of transfusion, of course, which is actually where transmission of bacteria is involved. So this is the most frequent infection associated with the transfusion and significant risk of transfusion, especially for platelets. So hemovigilance has got a definition of transfusion transmitted bacterial infection, which require that laboratory evidence of pathogen in the recipient, that's the first thing, and demonstration of pathogen in at least one or more of the following units. One of them, we have to demonstrate that responsible pathogen in transfused components. Secondly, the donor at time of collection. Thirdly, additional components prepared from the same donation. We have also to demonstrate the pathogen. And thirdly, additional recipients or of a component from the same donation. So when you are able to demonstrate that pathogen from those units, then you can then conclude this is transfusion transmitted bacterial infection, right? So a definition of definitive diagnosis of this TTIB or TTBI, transfusion transmitted bacterial infection, it requires that recipient did not have evidence of infection before the transfusion. If the patient had, then it's not a good thing. And also, secondly, septic correction caused by pro-inflammatory mediator are due to the gram-negative bacteria that produce endotoxin during storage. Of course, those bacteria that produce endotoxin can cause problem of pro-inflammatory mediators, which can lead to septic shock or septic reaction. So symptoms, actually, you find that patient is experiencing high fever, rigors, hypertension, tachycardia, nausea, and vomiting. So these are the prominent symptoms, and also pain, back pain, abdominal pain, as well as pain at infusion site would happen, and respiratory complaints can also occur in the patient. So there are so many symptoms a patient would develop, including septic shock, kidney failure, as well as DIC. Those are also other common complications of this patient. So thank you so much for joining us, and also maintaining attendance. I really appreciate, and God bless you abundantly.